Thank you for joining us for this presentation of hypothermia in the ambulatory surgical patient. We have two presenters for you today. The person that will follow me is Jan Allison. She, as you can see, is Director of Clinical Research at Azero Vascular Care and National Cardiovascular Partners, which is based up in Pennsylvania. And I am David Shapiro. I'm an anesthesiologist living in Florida, currently working at Red Hill Surgical Center in Tallahassee. Today's program is provided by the North American Center for Continuing Medical Education, which is, as you can see, an HMP global company. And this particular presentation is supported by an educational grant from 3M Healthcare, their Medical Solutions Division. Today we have basically four learning objectives that covers most of the material that we're going to present to you. First one is describing the significance of perioperative hypothermia in the ambulatory surgery setting. Second is recognizing several adverse patient outcomes related to hypothermia. And then going ahead and explaining why pre-warming is beneficial for the prevention of this hypothermia. So we'll show you why it's something to avoid and explain why pre-warming is beneficial. And then finally show you how to develop strategies that you can use for applying evidence-based practices for the prevention of the perioperative hypothermia that we're about to describe. So we're going to start out by defining some key terms that both of us will be using throughout this presentation. First one is normothermia, and that is defined pretty specifically as a core body temperature. And we're also going to define core body a little bit further on, but that's between 36 degrees centigrade and 37.5 or 37.5 degrees centigrade. And this translates into Fahrenheit at 96.8 to 99.5. So fairly narrow range. When we're talking about hypothermia, as we did in the title of this presentation, we're talking about anything of the core body temperature below 36 degrees centigrade or below that normal range of normothermia is listed above. And again, that translates into 96.8 Fahrenheit. We'll be talking about the core temperature, and that is really defined as the thermal compartment of the body, which, as you'll see on some diagrams in a couple of minutes, composed of the highly perfused tissues, where that temperature is usually uniform and also higher compared to most of the rest of the body. And I'm going to show you how that works in a moment. The ambient temperature, when we talk about it, really just means the temperature of the surroundings or whatever it is in the environment that you find yourself in, whether it be the operating room or, although we won't be talking too much about the outdoors when you are there. We're going to mention the ideal thermic state. And again, not surprisingly, that's a condition of a normal body temperature somewhere around the mid-range of normothermia, so around 37 degrees centigrade, or again, you probably heard this term, 98.6 degrees Fahrenheit. So let's again talk about that normothermic temperature range, which I've already mentioned to you. But again, we're just going to aim for the mid-range of 37 degrees centigrade. But it's important to know how that is regulated. So let's just talk about that for a couple of minutes. The strict temperature control is really important for all the bodily functions that need to occur to maintain homeostasis for any of us, regardless of what situation we're in. So that temperature control is kind of automatically regulated by the body within a really narrow range of about 0.2 degrees centigrade. And this, as again, you're going to see on some graphics in a moment, this is referred to as the intra-threshold range. So within this range, active methods of heating or cooling are not triggered because you're right within that sweet spot, if you will, as far as your body's homeostasis is concerned. In addition, there's a set point temperature within the body, which maintains the changes in core body temperature within the range of about 0.5 to 1 degree centigrade based on your circadian rhythms. So this temperature, as you probably are aware, tends to be decreased during sleep. And then, as you are also no doubt aware, increase with physical activity if you're exercising, walking, or playing any sports. So a little bit more detailed on temperature regulation. In the normal situation, and we're going to talk about how that differentiates itself from what occurs in the operating room, but that precise temperature regulation involves two things, mainly your peripheral and your central nervous systems through two mechanisms. One is behavioral and the other is autonomic, or using that autonomic or automatic nerve triggers. So afferent signals are processed differently for hot and cold, and we don't need to get too much in the details, but we've got those cutaneous sensors. So those are some of the receptors that are located in both the skin and also internally within the spinal cord. And then those temperature signals from the skin or spinal cord and other tissues basically travel to the primary area of temperature regulation. And that's, if you remember back to your basic science days, the good old hypothalamus. Obviously, the hypothalamus does a lot of other things, including regulate some of your hormonal activities. But today, we're really just going to be focusing on what that real important part of your brain does in terms of temperature regulation. So it pretty much all starts and stops in the hypothalamus. That hypothalamus then is what activates both those behavioral and autonomic responses to temperature changes. Again, this is in the normal state. So as I said, we really do in the normal state tightly control those core temperatures through a variety of mechanisms. Again, some are behavioral modifications, getting out of the sun, getting out of the cold, and autonomic nervous system stimulation. And we do things like sweat, we shiver, and do some other things to maintain our body within the range that it kind of needs to be in to function as well as it possibly can. So some of those behavioral changes that we're used to, like again, putting on more clothes or taking clothes off or moving out of the wind, those are more influenced by your peripheral or your skin temperature, how you're feeling on your skin. But conversely, that autonomic regulation, that real important internal regulatory mechanism, includes the peripheral vasoconstriction or vasodilation, and that is mostly dependent on that core temperature that we defined earlier. So the body is always exchanging heat. We lose heat through basically 4 ways: radiation, convection, conduction, and evaporation. And I'll briefly describe those, and then I'll kind of show you a little diagram to kind of hammer the point home. Radiation would be the infrared transfer of heat. Convection is basically the movement of heat based on the airflow. So if there's cold or warm air blowing, that will affect the peripheral temperature receptors. Conduction involves heat transfer through physical contact. So if you lie down, for instance, on a cold operating room table, some conductive activities occur which will transfer heat from your body to that cold surface. And then finally, evaporation refers to the loss of heat through sweat from skin or fluid loss from exposure of organs, especially if you're doing an open case, although we do certainly most of our cases these days laparoscopically, and so we have less time to be influenced by this exposure of internal organs to the open atmosphere. But certainly for plenty of procedures, in plenty of situations, that does occur. It is important to note that that significant heat loss, or most of it, 60%, occurs by that first thing I mentioned, which is the radiation or the infrared transfer. So here's a diagram to go over those 4 methods of heat transfer that I mentioned: the radiation, the convection, the conduction, and of course the evaporation. But remember that radiation is, as I mentioned earlier, that is where 60% of that heat loss occurs. So as I mentioned, I wanted to talk a little bit more about core versus peripheral temperature regulation, since they're obviously related, but they don't always track together. So that non-core peripheral tissues may fall significantly below those core temperatures. And you can see on the diagram that those core temperatures are the ones comprising those internal organs like the heart, like the lungs, all the things that keep us alive in the normal state. In a resting patient, or the way most of us are most of the time, a large portion of their heat is going to be generated by those internal organs. So the brains, the lungs, in the chest, and the abdominal cavity. So under normal conditions, we're really good, as I mentioned before, at keeping our body within that narrow range of temperature regulations. And we control the rate of heat loss from the core. And as you can see in the diagram, that peripheral temperature on the left during the cold can drop fairly low, while the core body temperature is still maintained within that normal thermic range. Equally as important in a warm environment, the same thing occurs, although of course the body is not trying to compensate for what we provide in the operating room setting. So what does go on in that operating room setting, and why is it so very important for us to be aware of as we're placing patients into our operating rooms throughout the course of our day? Well, a lot of factors, as you might well imagine, contribute to the perioperative hypothermia. Certainly operating room temperatures, and that would be, in this case, the ambient temperature that the patient's exposed to, contributes really significantly to that all-important radiant heat loss. Although most operating rooms have in-room thermostats, we often have maybe some issues, if I want to be politically correct, talking about different perceptions of the temperature in the operating room by various folks, often dependent on how they're clothed, what kind of gowns they might be wearing, what kind of protective PPE they might be wearing, and of course, how close they are to whatever, especially overhead lighting we have set up in the operating room theater. Again, additional heat loss occurs through conduction as the patient is positioned, as I mentioned before, on that usually super cold operating room table, and that occurs by convection and also laminar airflow. And as a matter of fact, one additional thing that isn't thought of too routinely, when we're prepping the patient, we're often slapping on some pretty darn cold solution that further aids in heat loss through the evaporative mechanism that I mentioned earlier. So let's talk about the causes of unintended perioperative hypothermia, and then we'll talk a little bit about why it's so important to avoid it. So first of all, most of the things I've mentioned are pretty obvious. So those exposed body cavities, especially when we're doing an open procedure, the cold operating room temperatures. Also, of course, the length of surgery is a variable that will influence how the temperature regulation is being conducted by an individual. And then, as I mentioned, not only that cold prep solution, but also we're infusing cold fluids, especially something like lactated ringers or D5W, whatever it is that you're using to administer your medication. Those fluids are usually fairly cool and serve also to add to the hypothermia potential for that patient. But I hate to admit this as an anesthesiologist, but we are also significantly, by delivering our anesthesia, very, very complicit in getting that patient to an unwanted hypothermic state through our administration of anesthesia. So I want to talk about that with you in a little more specificity. As I mentioned, though, under normal conditions, we wouldn't have to worry about this. We're really good at keeping our bodies within the normal thermic range. As I said, though, the anesthesias I'm going to show you really disrupts those homeostatic mechanisms. In anesthetized surgical patients, they really are unable to regulate their temperature through those behavioral changes, such as sweating if they need to get rid of heat, but also shivering, especially when you add in all of the things that we have done to them to provide their loss of pain sensation through the administration of anesthetics. They rely, of course, on the body's thermoregulation system and clinical intervention to regulate their temperature. So here's a diagram that at least enables me to visualize a little bit better what's going on. As I mentioned, we have the body's really good at keeping our cells in a normal situation within that 0.2 degrees Celsius intra-threshold range. And as you can see, on either side of that range, either the cold side or the hot side, we start to do things like vasoconstrict or vasodilate and shiver further along into the continuum, and or sweat if you're talking about getting dissipating heat from the body. But for the purposes of this discussion, we're really talking about the left side, if you will, or the lower amounts of temperature that the patient might become during the time that we're taking care of them. So we're really looking at how the anesthetic influences and really incapacitates to most extent the ability of a patient to do these things on the left side of the chart, such as vasoconstrict and or shiver. So this slide will show you how thermoregulation under anesthesia becomes impaired. What it does essentially is widen that intrathreshold range so that the patient can easily become hypothermic or achieve a temperature of less than that 37 degrees centigrade, as you can see on the left-hand side of the chart. Now, in addition, we have somewhat impaired their ability to change their temperature so that their core temperature can remain within normal range. So what I want to do with you is briefly discuss the effects of anesthesia and how it impairs those normal mechanisms. Basically, the thing to remember is anesthesia causes vasodilation. And I'll show you that in some graphics on the right side of the slide. It opens arterial shunts, which allows that warm blood from that red colored core to flow freely and mix with the colder peripherally. Then as that blood circulates, it will cool until returning it back to the heart will cause a drop in the core temperature, as you see on the right-hand portion of the slide. So as you can see, that core body has turned from red, if you will, to blue, indicating that those colder, cooler peripheral temperatures have mixed with those internal core temperatures to decrease, sometimes very significantly and very rapidly, the core temperature. So this is known in fancy term, because doctors like fancy terms, is known as heat redistribution, or RTD, redistribution temperature drop, but just a fancy way for describing what is occurring at the core. One important thing to note is that this occurs very, very quickly. So that core temperature can easily drop over 1.5 degrees in just the first hour of general anesthesia. And as we mentioned, most of this temperature decrease is due to that core to peripheral heat redistribution that I showed you on the prior slide. So while it's very difficult to treat this redistribution, what we really want to do is prevent it. And the way to prevent that is by pre-warming, because pre-warming basically increases the temperature of the periphery, which then will limit, and this makes pretty much good sense, the amount of heat loss from the core through that redistribution, or that core receiving those peripherally cold temperatures and mixing with the normally warm core temperature. So as you can see, it's really important to do this preventive measure, and we're going to be showing you exactly how to do that. As I said, the induction of anesthesia is also the most significant contributor to the perioperative hypothermia in surgical patients, but it really, really is important to know how quickly this can occur. And in fact, those effects begin way before that hour that I showed you on the prior slide. So obviously, reducing the impact of the redistribution temperature drop through pre-warming is a really, really effective way to maintain patient normothermia, which, as I'm about to show you, is exactly what you want. I did want to mention, since I just talked about general anesthesia, regional anesthesia in some regards is a great alternative for our patients. But unfortunately, in this regard, as far as the perioperative hypothermia, it does not alleviate the problems that are caused by general anesthesia. For some of the similar reasons, central and peripheral thermoregulatory functions are impaired when you give a spinal or an epidural or any kind of neuroaxial anesthesia. So the normal responses, again, are going to be disrupted, and the normal nerve conduction is going to be disrupted, which of course is the point of giving those regional anesthetics. But because those skin temperatures are blocked by the anesthetic, they're misjudged by the thermoreceptors. Patients will also actually feel warmer due to kind of mistaken perceptions of their blocked thermoreceptors that they're used to getting really good messaging from. So hyperthermia, unfortunately, is frequently undetected with patients under regional anesthesia, mainly because core temperatures are not usually monitored as frequently during this type of anesthesia. And also, we don't have the patients who are often awake or just mildly sedated. We don't typically have them express to us as anesthesia staff their feelings of being cold during their procedure. So as I said, I wanted to just mention for a couple of minutes why it is so important to maintain this normothermic state in our patients. What we got on this slide here is the negative outcomes associated with that inadvertent perioperative hypothermia. And again, there's a definition. But as you can see here, the negative effects really cover the waterfront. The ones elucidated here are basically the 7 deadly sins, if you will. And it really affects a lot of parameters that we need to be acutely aware of as we're ushering our patients through the perioperative period. I'm going to discuss, I think, 5 of these in a little more detail than is shown on this slide. So let's take a look in a little more detail on the clinical implications of this perioperative hypothermia and why we really do want to avoid that. First of all, drug metabolism. That mild hypothermia is going to reduce the effect of some enzymes that would usually metabolize and essentially clear anesthetic drugs from the system. So what it does, and naturally, is increase the duration of anesthesia, usually past the point where we want the persistence of the anesthetic effect to prevail in our patients. One of the things that we've seen in animal studies are even the drugs that are given as volatile anesthetics, so things that we deliver through the vaporizers like sevoflurane, will also be increased in potency, so that again, we're delivering a little bit more anesthesia than we would have expected to deliver by just looking at the concentration of inhalation anesthetics or the amount of medication given through intravenous anesthesia. So again, I've named some drugs in the lower portion of the slide, but really it pertains to essentially every drug, because all of the drugs that we give are then metabolized through the liver, and the metabolism is going to be impaired by this mechanism. So one of the things that does naturally is increase the length of hospital stay if patients are staying in the hospital or whatever facility you work in. Basically, that PACU or post-anesthesia recovery unit time is going to be delayed, sometimes significantly. So we have some studies that have shown us how much that PACU discharge times are impacted. But I think it really, really shows the effect of hypothermia on the patient and how this increased anesthetic effect is going to prevail past the anesthesia that is delivered in the operating room, way after the patient is taken to the recovery room. So something that we probably don't want to occur in most situations. Most often cited cause of blood loss or mechanism is this hypothermia-induced platelet dysfunction and coagulation dysfunction, caused again by reduction in the efficacy of the enzymes that lead to the coagulation of the blood within the patient. Surgical site infections and surgical wound infections are something that we are always on the lookout for. And unfortunately, that's even mild hypothermia has been associated in many, many studies with increased risk of surgical wound infection, basically due to the mechanisms that I've spoken about before, such as the vasoconstriction that especially occurs at the periphery, and also the change in oxygen tension that occurs due to the mechanisms we've described. So because the oxygen delivery to the subcu tissue decreases, that impairs the strength of the collagen and really, really prolongs healing, as well as a setup for infection. So this, you can see there's results in some studies. A lot of them have been conducted during colorectal surgery. And as you can see, that hypothermic group had a very significantly higher incidence of wound infections, which can be tragic, unfortunately, compared with a much lower percentage in the group that was kept in a normal thermic state during their perioperative period. One thing that we also see, and moreover in this instance hear about from our patients, is that really uncomfortable feeling of prolonged and pretty severe, in a lot of cases, shivering that occurs for patients and starts as the anesthesia is wearing off and usually hits hardest while they're in recovery room and have regained their consciousness. So shivering then is about 4 times more dependent on the core temperature than the skin temperature, but even core normothermia does not guarantee that shivering will not occur. And then there are some results of some studies up on the slide, but I think that the most significant take-home point is that vasoconstriction hypothermia are usually resolved by postoperative day 1. But in the meantime, the patient has a lot of thermal discomfort, some severe shivering. And in these days where we're really even more conscious than we've ever been about patient perceptions of their intraoperative and perioperative experience, we really want to avoid this perioperative hypothermia not only because of the patient's experience of shivering, but also because of all the attendant other metabolic issues that we're describing right now. So one of the other reasons that we need to be aware of this possible perioperative hypothermia, if you're working in the ASC or ambulatory surgical center environment, we do have a measure that we report to CMS, and that is listed as ASC 13. It's also referred to by its title of the normothermic outcome measure. And this is a measure whereby you're taking the number of patients with a body temperature of at least 36 degrees, taken within 15 minutes of arrival in the recovery room, over all the patients who were given surgical procedures under either general or that regional neuraxial anesthesia of a duration greater than 60 minutes. And then that will give you the percentage that you are then mandated to report to CMS. So again, that outcome is basically measured as a percentage of patients having surgical procedures under the general or neuraxial anesthesia of 60 minutes or more in duration, who are normothermic, again, that's what we're aiming for, within 15 minutes of their arrival in the PACU or recovery room. To do this, basically what you need to do is be aware that the submission of this data will occur from the January 1st to about May 15th of 2021. And if you'll recall, this measure works the same way that all the other CMS measures do. If you are CMS certified and you do not report on all the measures which you are required to do so, you will receive 2 years after, so in this case, the calendar year of 2023, a 2% reduction in your total Medicare payments. So to those of you who are doing a lot of Medicare patients or Medicaid patients in your organization, you really do need to have a defined process to manage the data collection so you can actually report this to CMS. And in addition, really provide the staff education, including the prevention of inadvertent perioperative hypothermia. And that's what we're going to be talking about in a moment when Jan starts describing to you how to achieve that. So please remember that one of your responsibilities in this regard will be to have a defined perioperative temperature management protocol in your facility for all the reasons I've elucidated, but if for none other, just to be aware that you do need to report these statistics to CMS if you are participating as a Medicare facility who treats Medicare and Medicaid patients. Before I turn it over to Jan, I just want to present a summary of some of the main points that we've discussed. First is that this perioperative hypothermia is, of course, very, very prevalent, but also it is, moreover, a preventable complication of surgery. We really can do a lot to prevent this from happening to our patients. Also remember that 81% of the temperature decrease occurs really rapidly or within that first hour of anesthesia. And again, that's due to that core to peripheral heat redistribution, or as I mentioned, sometimes abbreviated as RTD. And also just remember that even the mild state of hypothermia can result in some significant negative outcomes, as we've discussed. And finally, it is difficult to really treat it. So once this redistribution has occurred, it's really hard to reverse. So what we want to do, and what we're going to be talking about now, is how to prevent it by pre-warming our patients during the perioperative period. So I'm going to turn it over to Jan to explain why pre-warming is beneficial in the prevention of this unintended perioperative hypothermia.
Hello, everyone. I'm Jan Allison, and I'm going to share with you on this next area of discussion about why pre-warming is beneficial in the prevention of unintended perioperative hypothermia. Now, I know this answer may seem self-explanatory, but let's ask, what is pre-warming? Because we learned from Dr. Shapiro the impact that anesthesia has on the patient's temperature, and that pre-warming is an effective way to help maintain patient normothermia. Now, pre-warming is the application of heat to the patient prior to anesthesia. And prior to anesthesia, that's the key. That effectively loads the body with heat, also known as heat banking. Then the patient's core temperature will decrease less once anesthesia is administered. It is always better to be proactive by preventing hypothermia through pre-warming than reactive by trying to resolve it intraoperatively or postoperatively. So most patients who arrive for outpatient surgery are normothermic, and this leads some to believe that pre-warming is not necessary since the patient's temperature isn't changing in the preoperative area, or because the procedure is short. There's not enough time for the patient to become hypothermic. But patients having shorter surgeries are more likely to experience postoperative hypothermia because there's simply not enough time to bring the patient back to normothermia in the operating room. Patients who undergo a shorter procedure who are properly pre-warmed and receive intraoperative warming, they can remain normothermic throughout their perioperative journey and should not require rewarming in the post-anesthesia environment. So warming a patient before anesthesia induction, regardless of the length of surgery, is an effective way to help prevent intraoperative hypothermia before it even begins, as it helps to put off anesthesia's impact on core body temperature regulation. So when should we begin pre-warming? The active warming device should be started as soon as possible when the patient arrives and prior to the induction of anesthesia. There are really two approaches of warming for patients. Passive warming is applying a layer of insulating material on the patient's skin. And we see that frequently with warm cotton blankets, putting socks on the patient's feet, wrapping their heads with a cover, and of course the surgical drapes. But it can even include increasing the ambient temperature in the room. The other type of warming is active warming, which is the active application of heat. And this includes conductive fabric apparatuses, circulating water devices, fluid warmers, and forced air warming. Our goal is to maintain the patient's core temperature, and some of these methods have proven more effective at doing so than others. So let's talk about cotton blankets for a moment. Now, I started working in the ambulatory surgery center industry more than 30 years ago. So cotton blankets then were the primary choice of warming the patients after they arrived to the preoperative area. Now, as this practice continues to remain quite a popular choice for a number of ASCs, because cotton blankets will serve well to make the patient feel warm and comfortable, but research shows that the heat that they give off only lasts about 10 minutes, as the heat from the cotton blankets, it rapidly dissipates into the environment, making little difference in terms of maintaining the body's total heat content. You want to consider too the linen cost and inventory that's increased, and staff must dedicate time to loading blankets in the warmer and reapplying blankets in pre-op. And research has shown that patient heat loss is nearly the same with warm and unwarmed cotton blankets. Other modalities of pre-warming include convective and conductive warming. Convective warming systems and conductive warming systems warm the patient in very different ways. Convection, it's the transfer of thermal energy through the movement of a liquid or gas. An example of this is a forced air warming blanket that circulates warm air around the patient's body. And I will be discussing that more at length coming up. Conductive warming is the transfer of heat between substances that are in direct contact with each other. And the next slide provides examples of conductive warming. When using a conductive modality for warming, you are applying a device in direct contact with the patient's skin for transferring heat from the device to the patient. Examples of conductive warming, this includes the warm cotton blankets, which we've discussed, that are warmed in a temperature-controlled incubator, your blanket warmer. It could also include electric blankets that have an inbuilt heating device. And there are circulating water mattresses, which are thermostatically controlled, and even a circulating water garment, where a heat pump circulates warm water through a garment that the patient wears. Another example of conductive warming is a resistive electric cover. Now, resistive heating is achieved via an electric current that flows through a type of material that has some resistance, such as a polymer or carbon fiber, and this is to generate heat. Also, there's heated pads, which may be a heated gel pad or gel-based mattress that is thermostatically controlled. Multiple studies have been done on different types of warming devices, and I want to spend the next few slides reviewing the effectiveness and challenges with these devices. Now, I can't think of a circulating water mattress without remembering the waterbed that I slept in my younger days. Now, while I didn't fall in love with sleeping in a waterbed, I will say the greatest pleasure was the heated water and the initial climbing into a warm bed. Circulating water devices, they operate by passing heated water within the mattresses, blankets, or even garments that are in contact with patients. And while in theory, it seems to be a very effective medium for transferring heat, when it's a mattress, it would require the mattress to have unobstructed high thermal contact with very well perfused skin. However, when the patient is in a supine position, the skin's posterior surface is poorly perfused from the weight of the body compressing cutaneous capillaries. And water mattresses operate at somewhat lower water temperatures in order to prevent pressure heat necrosis. Every warming device has the potential to cause burns, and there have been documented cases of thermal injury involving water warming devices. And as a side note, circulating water garments that have shown greater promise in achieving significantly higher core temperature profiles in some of the major surgeries, these are ones that are performed in the acute care hospital setting. So the positive with resistive electric modalities is it's reusable, it's energy efficient, easily cleaned, and relatively silent. So it has been promoted as more cost effective than other modalities, but studies evaluating resistive heating performance in preventing and treating hypothermia have shown mixed results in comparison with alternative warming approaches. It is certainly better than passive warming or no warming at all. As heat transfer via resistive heating is critically dependent on skin contact, the variable designs and types of blankets or mattresses are likely to significantly influence performance. But studies show temperatures are higher intraoperatively in the patients warmed with forced air warming as compared to resistive heating. Hypothermia at end of surgery was lower in patients with forced air warming, and patients were rewarmed following surgery 2 times faster with a forced air warming blanket versus a resistive electric full body warming blanket. So now let's move on to talk about forced air warming. It provides heat through convection, which, if you will recall, is the transfer of thermal energy through the movement of a liquid or gas. Forced air warmers operate by distributed heated air generated by a power unit through a specially designed downstream blanket or gown, resulting in heat transfer to the covered body surface. Now, this is the most commonly tested body warming modality and is unsurprisingly associated with significantly higher postoperative core temperatures when it's compared with patient control groups where no warming was used. Forced air warmers have also been evaluated against certain types of passive insulation, including the use of cotton blankets, reflective blankets, and sleeping bags. And these studies have shown superiority of forced air warming both to prevent postoperative hypothermia and to rewarm already hypothermic individuals. Now, take into account that forced air warmers prevent hypothermia not only through heat transfer, but also by stopping convective and radiant heat loss from the exposed skin. The surface area covered by the warming blanket also has a significant influence on forced air warming performance, as greater coverage both reduces exposure and offers a larger interface for heat transfer. But studies have shown that even when only half of the body surface is covered during surgery, forced air warming can provide effective warming therapy. Now, on this slide, you can see a graph to your right of one study that shows the trajectory of the patient's temperature with different types of warming modalities. Now the blue line, it reflects forced air warming, and it is the only line that demonstrates a maintenance or increase in body temperature over time. Now, I'd also like to point out that while many studies show a benefit in the use of forced air warming devices to reduce the risk of perioperative hypothermia, it is also beneficial to add the use of warmed IV fluids. Now, warmed fluids do not actively warm the patients, but infusions that are below body temperature can be regarded as a form of active cooling. So it's therefore unsurprising that the studies where convective and fluid warming were combined show less accidental perioperative hypothermia than convective warming alone. When you research guidelines to support normothermia, the recognized professional societies that are referenced in the ambulatory surgical setting all support pre-warming and forced air warming. And this is reflected in the American Society of Perianesthesia Nurses, better known as ASPAN, the CDC, AORN, and the National Institute for Health and Care Excellence. Now, it has been debated in the past that forced air warming disrupts the operating room airflow and contaminates the sterile field, leading to surgical site infections. ECRI, a widely respected nonprofit that assesses the quality and effectiveness of medical devices, reviewed more than 180 studies about patient warming and surgical site infections. ECRI concluded that there is a lack of evidence to establish that the use of forced air warming increases the risk of surgical site infections compared to other warming methods. Based on its review, ECRI found insufficient evidence to justify switching from the use of forced air warming devices. Studies have demonstrated that the airflow caused by forced air warming is well counteracted by the downward laminar airflow that comes from the ceiling in the ORs. Thus, it would be less likely to cause surgical field contamination if you've got the presence of sufficient laminar airflow. Another debate suggests that forced air warmers may also harbor microbial pathogens that have the potential to be emitted into the operating room environment via the air warmer hose. However, if you have the correct use of microbial filters, and the recommended perforated blankets have been shown to prevent that transmission. So in summary, there are no studies that have demonstrated forced air warming contributes to a greater risk of surgical site infection. So, how can we develop strategies for instilling evidence-based practices in the prevention of perioperative hypothermia? It starts to be a mouthful, doesn't it? So hopefully you have a robust quality improvement program where you not only review processes from a reactive approach, but look at your processes from a proactive approach as well. What is your current approach to preventing perioperative hypothermia? How do you know it's effective? If you haven't done a QAPI study on this measure, I recommend you do so, especially if you are not pre-warming patients just because patients undergo short procedures. Do you find yourself with shivering patients in the PACU? Are you having to apply multiple warm blankets to help get them warm? Are you monitoring the patient's temperature on arrival to the PACU or only upon discharge? It is worth noting that treating postoperative hypothermia in the PACU is substantially more expensive than helping to prevent it in the preoperative area. Do you have a single temperature monitoring method? Are the temperature monitoring devices standardized in all areas where the patient's temperature is taken? Is the device you are using accurate and intended for use in the healthcare setting? Are staff competent in using the device in accordance to manufacturer's instructions? It's important to note that there's no inconsistency in the method of your temperature taking because that could impact the effectiveness of your warming practices. Because maintaining core temperature is associated with better patient outcomes, the accuracy of the instrument used to obtain that measurement is of great importance. And while this presentation has discussed the importance of normothermia in all surgical patients, there are patients who are definitely at higher risk for hyperthermia, As Dr. Shapiro discussed earlier, that risk of hypothermia is particularly high in patients over 60 years of age with poor nutritional status and pre-existing disease that might impair their thermoregulation, like patients who may have diabetes and have neuropathy. Patient size, comorbidities, the projected duration of the procedure, all can strongly, uniquely influence the hypothermia risk. And there are risk assessments that we commonly perform in the surgical setting already, like those patients who may be at risk for DVTs, risk for fall, a fire risk in the OR, depending on the surgery. So are you assessing for a high risk of hypothermia as part of your preoperative assessment? Another consideration in maintaining normothermia in patients is increasing the ambient temperature for both the pre-op and the OR. Now, granted, the ambient operating room temperature has a negligible effect on core temperature for patients in whom forced air warming is used. But if you choose not to use forced air warming, it is apparent that patients in cold operating rooms will lose more heat than those in warmer rooms. Of course, it is also important to ensure surgeons stay comfortable, so you can always consider use of a cooling vest if needed. Consider adopting a clinical practice guideline in your facility for the prevention of hypothermia. Developing a clinical practice guideline will communicate to your staff a standardized, proven best practice that is intended to optimize patient care. That's the purpose of a clinical practice guideline. And because the dynamic of every surgery center differs regarding the volume, length of cases, the scope of services, and the type of patients that are served, each surgery center should evaluate how pre-warming may help the patients and which forms of pre-warming are best served for their situation. The Agency for Healthcare Research and Quality, known as the AHRQ, it actually provides a normothermia audit tool. So if you do this for a QAPI study, you've got a tool already at hand. And it will help your quality improvement team understand how consistently you maintain normothermia standards in the operating room. It can help your team identify practice patterns so you can more easily pinpoint opportunities for intervention. Now, you can find this tool on the AHRQ website at www.ahrq.gov. It should never be assumed that all of your clinical staff and physicians are well versed in the importance of and all the actions involved in maintaining normothermia. Education and training should include the appropriate assessment for patients who are at high risk for hypothermia and the type of complications that it can cause. Competency in the use of all the equipment, and this includes the use of your thermometer, because studies have found that user error is the most commonly cited cause of temperature inaccuracy for both the tympanic and the temporal artery instruments. Also, education and competency in the use and maintenance of blanket and fluid warmers. I mean, some who have been in the industry a long time may continue to place blankets and fluids in the same warmer simultaneously. Fluids hold significantly more heat than blankets and present a greater burn risk if the temperature exceeds the recommended temperature of 110 degrees Fahrenheit. Now, if you do take your fluids and store them separately in their own warmer, then temperature settings on blanket warmer cabinets can be set to a maximum 130 degrees Fahrenheit. If your center applies forced air warming, although rare, forced air warmer use has been associated with thermal injuries in patients. But the underlying causes in the majority of cases involve human error, such as the incorrect assembly of the warmer hose to the blanket and incorrect positioning of the exit vents. So include adequate training and competency in the staff who assemble and maintain the forced air warming device. To assure patient safety, the warming device should be used according to the manufacturer's instructions for use, the IFU. And training should also include how to clean and store the devices according to manufacturer's IFU. I would also like to point out one more area of competency, and that's documentation. Documentation is a communication tool, and poor documentation is perhaps one of the most prevalent problems in medicine. When documentation is accurate and complete, It works wonders at telling a patient's story and can even improve patient care. Poor documentation is anything that inhibits a clear presentation of a patient's story. The care that you take in documenting assessments, interventions, and compliance with required processes could prove that you met the standard of care and establish your credibility with the jury if it ever came to that point. So, to demonstrate your efforts at maintaining a patient's normothermia, documentation includes patient risk assessment for inadvertent patient hypothermia and planned interventions for pre-op, inter-op, and post-op warming to prevent inadvertent patient hypothermia. Now, body temperature is just as important of a vital sign as the blood pressure or pulse for surgical patients, and guidelines, they do vary in the recommendations for how often the patient's temperature is checked. But studies recommend that the temperature should be recorded every 15 minutes for general anesthesia patients. So that's part of the documentation you may wish to consider you're making. And last but not least, consider inclusion of your assessment and action items for maintaining normothermia into your timeout. So maintenance of normothermia has become a standard of practice. As discussed earlier in this presentation, the consequences of perioperative hypothermia are significant, and they may include increased intraoperative blood loss, increased chance of surgical wound infection, increased length of PACU and overall stay, decreased patient comfort, poor incision healing, post-op pain, and increased rates of cardiac events. Avoidance of perioperative hypothermia became an important quality performance measure in recent years, as Dr. Shapiro pointed out, and it was aimed at optimizing the care of surgical patients. Guidelines have been updated in the past few years as evidence continues to mount and support more detailed recommendations to improve hypothermia prevention. There are several important ways for teams to put prevention of hypothermia during surgery into practice. And we've discussed these. I'm just summarizing them quickly for you. One, you want to assess every patient preoperatively. This is to determine the best method of hypothermia prevention, including active warming, passive warming, or a combination of the two. Pre-warm the patient. If the patient is not pre-warmed prior to arrival in the OR suite, the active warming device should be started as soon as possible when the patient arrives and prior to the induction of anesthesia. Monitor the patient throughout intraoperative care. Anesthesia exposure is associated with 80% of heat loss in surgical patients, and this is why it is important to implement active warming methods on hand, as these are the only methods that counter the effects of anesthesia. And continue to manage patient core body temperature after surgery. A postoperative focus on achieving patient normothermia should continue in the postoperative care area until the patient's temperature is stabilized. Even today, a large majority of surgical patients continue to be affected by hypothermia, whether due to warming systems being underutilized or poorly utilized. The information provided in this presentation should encourage professionals to make the best possible use of active warming systems and monitor patient temperatures in order to better identify the prevalence of hypothermia. Thank you for joining this program, and it is now concluded.